And this is Sandy.
Sandy Vandertye. I am the Director of Outpatient Services.
And she has been in the hospital systems for well over 35 years.
It'll be 37 years on November 2nd.
And today's podcast, we're going to talk about listening in the emergency department. Is the emergency department the most critical environment for listening that exists in the world?
There's no other place I'd want someone to listen to me than when I go into the emergency room. So I'd say it's important.
What about your dining room table?
No one listens to me there. Yeah.
But if you go to the emergency department, if you need to go to the ER, you want to be listened to.
You got it. From conversations to the natural world to complete silence, so many of us focus on what's next rather than what is happening now. I'm Listening is a podcast that dissects the importance of listening.
I'm Drew Richmond.
And I'm Brand Christofferson.
And this is I'm Listening, a podcast simply about the skill of listening. Sandy, I'll throw the question to you. Is the emergency department the most critical place for listening?
Well, I might be partial to the environment of the emergency room, as it's been part of my professional life for most of my working profession. I would say it's pretty invasive in healthcare in general. The emergency department is a key opportunity for listening and having your skills be honed. It's a huge part of the nurse training to be able to have questions posed to our patient, and we need to listen for that information because it's what helps us diagnose and treat you.
It can be general health, but it can also be, especially in that area, it can be life and death.
Absolutely.
Life or death. It
Absolutely.
can be both.
Mm-hmm.
Yeah.
Let's back up a hot second. Sandy, in your opinion, in your professional opinion, what's the purpose of the emergency department? Why do they exist?
Why do they exist? They exist because human beings get sick and get injured and need to have access to get care immediately. So we have 911 systems or EMS systems to go to the source of where they're hurt, injured, or ill and bring them to locations that can provide that immediacy of what we call triage in the emergency room, where we can triage people for the level of ill or injury and be able to then basically decide who gets seen first.
A couple different pieces you kind of layered in there. First, starting with just the immediacy of things, right? So when someone gets sick or someone gets injured, unless you're Drew's like, well, yeah, I'll just,
I only want to see
I'll wait.
My emergency staff at the grocery store.
At the grocery, yeah.
That's best.
That's probably
That's
good.
the best.
That is
Or
best.
out to dinner.
Yeah.
Out to dinner.
I grew up with my mom as a volunteer paramedic.
Oh,
And, she'd have a pager on her all the time, and that thing would go off, and I'd be like, all right, there she goes. And, I was curious to hear what the call was. If it was a car accident, a lot of snowmobile accidents in northern Wisconsin, just different things like that, where it was immediate. That response time was of the essence, and getting response and getting that person to the emergency room was crucial. And I don't know, like Drew, you were saying before too, like the importance of listening in that sense, like you've got to be on your game. Well, yeah. What is it like when someone is coming in to the emergency room and it is an emergency?
it gets everybody excited because that's, from a perspective of those of us that gravitate to that environment. Not everything we see in the emergency room is truly emergent. So when those true emergencies happen, it sounds weird or maybe not even tactful, but we get excited because that's what drives our adrenaline. That's what we're here for. So there are tons of processes. So it depends on what that is. If it's a trauma, is it a heart attack? Is it a stroke? Those are the things that kind of level up really quickly. And we have processes that are embedded into the emergency room that just take those right to the top. We send out communication to get all the right people at the bedside immediately because time, like you said, is absolutely of the essence. The golden standard's 90 minutes. The longer it takes you to be able to find those things, the higher the likelihood of a poor outcome occurs for that human being. So we are on our game.
So you say an emergency. There's the things that are emergencies and there are things that maybe aren't quite emergencies. Sometimes for me, it feels like an emergency to me when I'm coming in. But for you on the other end, when you're trying to triage things, you're like, no, dude, you're fine. You've just got a cough. You're okay. How do you help manage people when you're trying to triage?
So there is education. It's called the Emergency Severity Index that is trained on. That is what helps lead. I would tell you sometimes just training, like I could teach Drew ESI. He would just need a little companion to how to collect vital signs. But I would tell you Drew would probably do a better job of actually doing that algorithm better than I would, because I've seen too much, heard too much, or I've had bad things happen. It gets gray for some of us. But if you truly work the algorithm like it's supposed to, it's the vital signs, little things that you pick up on, the young woman who just had a baby 3 weeks ago and her heart rate's high and she's having difficulty in breathing. It's like ding, ding, ding. Those things will rise to the top because she's probably got a pulmonary emboli or a blood clot in her lung. So it's those kinds of things that you have to take a little bit of what's been going on, what they're presenting with, what are they telling you? And then I have these other scientific things that put it in the background to be like, yep, we have a winner here. This is somebody that's going to level up and get a room right away in the emergency room.
There's listening, but there's that level of understanding behind that. You talked about a patient that has increasing heart rate, decreasing blood pressure, increasing respiratory rate. That's one thing. But then to add on, oh, they recently had given birth a couple weeks ago, that's going to change the picture for you completely. Me, as someone who doesn't have a medical background, be like, I have no idea what that means, right?
Yeah.
But what about that sticks out to you as, oh my gosh, this could be bad?
Yeah, so it's the pathophysiology of some of those things that women who've given birth have a higher risk, and surgeries are risk. Also some other diagnoses out there, some cancers that can increase risk. So we just know that. That's part of our understanding how those systems work together. And it's, I don't want to say a common, but it's something we see a little bit more with regularity that you should be able to identify. Now, in the contrast, you might have somebody come in, for example, who's having chest pain is a great example, right? Chest pain can get people really anxious, rightfully so. People have chest pain for a lot of other reasons other than having a heart attack. You might come in and we ask all those questions. Do the vital signs, what's your body habitus? Do you smoke? What's your family at risk things? And that might be somebody who is like a 55-year-old guy sitting that you're having this conversation with. We do a 12-lead EKG and it's completely clean. And it'd be like, I know you're having chest pain. You got to validate what they're feeling and hearing. So it's like you got to try to convince them that they're not the highest priority. And sometimes that's easy. Sometimes it's not. What's happened in that person's background. Maybe their dad passed away at the age of 55 from a heart attack. Those are all the things you try to vet out in that listening and connecting with them to try to ease their anxiety and anxiousness. So we validate what they're saying. So that's the listening piece. We're validating that, but yet trying to kind of take on their anxiousness and say, we got you. You're going to be okay.
Can you talk a little bit about what trauma-informed care is in regards to listening in the hospital field?
That's where compassion and empathy come into play, and having to recognize that each single person has stuff in their background. And that stuff in their background can and often in the emergency room comes forward and can be presenting in a way that might not be their usual. So we have to navigate a lot of behaviors, and it's been more significant in the last few years. And so we just try to train staff about trauma-informed care. We try to remind about not getting jaded. all of those things, because when those begin to happen for you as a professional, your listening declines significantly.
Yeah.
So, the depths of trauma informed care, that could be a whole podcast probably forever that we could talk about.
That really could be, yeah. It adds depth to patient care because there is just looking at the physiological aspect of a patient, but then there's looking at the whole psychosocial compact of the patient, and you're managing both of those.
Yeah.
As you're working through that.
I get tons of examples of that. The funny ones, to share is or what we deal with in the ED is you have a husband and wife scenario. It's the male is the patient, and he'll be coming in. I'll use chest pain again. And as you're working them up, so they get into a room, and now I do that initial assessment or trying to do that physical assessment along with their deeper medical history. And you try to get to their what? What happened that said, drop everything, come to the ER. What often we hear is well, my wife made me, is one. My wife made me.
Yep.
And so she's the decision maker right off the bat. Or the other thing is, again, like I said, they have a backstory or a history of somebody in their life that something was similar and had a really bad outcome, and that's their driving force. So their what might be, I'm afraid I have an aneurysm. Great. That helps immediately have a conversation about all the reasons why it may or may not, and how these are the tests we're going to do to help prove that one way or the other. And while you're here, we got you, monitored. So all eyes are on you all the time, and just try to, again, alleviate that worry or that anxiety, and just being available to them.
First off, this is fantastic because I think this gets to the heart of, you've got this clinical process, but then you also have style. So my next question is, how much of this is in the realm of listening, the skill of listening? How much of it is taught and how much of it is learned?
So our personalities play a part in that, and our availability. So listening, I would tell you, to be a really good listener is something you have to continually work at. We bring it up in leadership all the time. We'll, sometimes somebody will read an article and then share it. Even listening today with the processes of communication, we recently talked about that everybody just wants to text message. Do we even talk to each other anymore? What's there to hear? You hear it very differently over texting than you do over a conversation. Thankfully, in the ED, it's face-to-face, so you get all of the elements that play in there. As a new nurse working in the ED, as somebody who hires anybody coming to the emergency room without experience, I would tell you it takes about 2 years for a nurse to really get what I would say, get their groove on. You get your mojo. And I'm really open with that, so people don't let themselves down over that period of time. You have to have the experience to get to a place to be I'm confident in my skills. I'm confident that I can, care for you in a critical situation, that now I'm fully available to actually listen to you.
Confidence, there's listening, but then there's the confidence in being able to respond or react to what you're hearing.
Yeah, and a lot of listening, sometimes this happens, but you listen to respond. That's not really listening. And we try to do things fast. And this is where sometimes we get hung up, or assumptions can get made, is if you're asking things at a rate that a patient can't process, they're never really answering your questions. You're kind of assuming the answers. And that can lead down a path that's not really well served for our patient or client. So we really do need to be cautious with that. And that's always a fine line. And that's why I think listening is so important to be a skill set that we're always practicing.
I like the way that you phrase that in the sense of getting your groove, because I can hear it through how you're describing it as well. It's your tempo. It's what you're listening for. It's what you're asking. So you have this clinical, what I would consider clinical training, if this, then that, those sorts of things, like the diagnoses component, the monitoring, all those things. but this ability to get the answers you're actually looking for, to enter that situation in a calm, relaxing way, to ask the right questions, but also to hear the correct responses. You don't just get that all dialed in on day one. You don't get that dialed in on day 400. Like, it takes a couple of years to get that all figured out. It's fascinating. I think it's a great lesson of listening, because you said it there too. You're always trying to get better. And that's the idea behind this podcast. What are these different examples in this world that we can share with people literally all over the world of how you go about listening and building the skill of listening? When we look at what's happening in the emergency room under my wife made me come here, but there is maybe a problem, versus somebody that's in a real crisis situation, you're dialed into the listening. Let's shift it over a little bit to medical staff to medical staff. Is it more scripted in terms of, okay, now we've got the information we need, now we go this route? Or is there a little bit more tolerance for general listening?
That is too somewhat where the training comes in, or experience. But a lot of the emergency department is by evidence-based care. So we take all that science that all of us nerdy people have, researched that, and there are things that are best practice. And the goal is for people to be following the best practice so that care, it looks the same, whether it's your chest pain or Brant's chest pain, that, where the screening tools are all the same. Where it becomes variation is then, I think, where listening comes in. And you have to ask certain questions. So in the ER environment, the way that process works, a patient comes in, they come through triage. If they get to a room right away, a nurse is in there to check them in, do a quick assessment, because there's some key details that's really important for the physician as they enter the room, like vital signs and some key things. So that kind of goes very linear. It goes pretty smoothly, unless, you walk through the front door with a slumped child that's unconscious, then, everybody is at that bedside and we're all trying to do our portion of that work immediately. But from provider, that nurse will give a little bit of a report to the provider. And that's, again, something that's trained is like, it's facts. It's not your feelings, it's facts. Because feelings is where we can go wrong really quick. So we try to keep that out of there. And that is hard for some people professionally, because your brain is busy putting people in buckets. You really have to train yourself not to do that, because you will get in trouble.
When you get beyond the basic introductory protocol, and there needs to be clear communication, there needs to be clear listening from that point forward to continue through the process of either sending you home or moving you on to another set of medical care through this triage process. Talk to me about what listening is in that sense. How critical is it? Or is it more just scripted because you can't have room for error? What does that look like?
Well, I would tell you healthcare is riddled with opportunity. In the news, you think about litigation and things like that. So, there's a lot of literature out there about that. You've got certain industries that have done a really great job, like, flying, the checklist and things like that. So we have attempted to take things that are really successful, embed that into our work to prevent errors from happening. Communication, I'm going to tell you, sits at the very top of anything that goes wrong in healthcare. It is related to communication. That's why we have surgeries, that there's a timeout process, that everybody has to state, we're doing the left hip on Mr. Da-da-da with the date of birth of this, and the patient has to say yes, and they're marked. So that's come over time in my career, that I've seen a lot of those things change to prevent errors from happening. So communication, you want your nurse that you've had a relationship taking care of you. Oh my God, she's going home, or he's going home. And you're like, what am I going to do now? Right? So it's like, how does that nurse carry you and keep your anxiety down? And you do that by bringing in the person that's going to be taking care of you, introduce them, acknowledge you as the patient, I'm going to do a handover report to the person that's going to be taking over for me, and I want you to be involved. So those are things that we've researched and have embedded into our work now. Most of us do it that way, where it's all face-to-face. Even physicians, when they have to hand over work in the ED, because it's shift work for them too, we really want that to be involving the patient, because there might be that key element that we didn't say, and the patient was like, well, actually it happened like this, or this is when it started. You guys maybe know the statistics, like if you're having a conversation or you read something, what do we actually even retain from that conversation? It's small. It's really small.
Yeah.
And so then you think about, like, again, text messaging. We have text messaging type processes in healthcare too, platforms that we talk, which there's efficiencies with them, but it's not any human interaction. And the efficiencies are like this. I'm typing something out to Drew. I don't have to interrupt Drew in a patient helping somebody to the bathroom, but he's going to pick up that message the minute he has a moment. So there's efficiencies, and then there's the downside to everything. Does that answer that question?
Yeah, that helps, because it's not surprisingly, there's a balance in there. You do need to have that human component. You do need to have that ability to listen and ask the right questions. What I heard in there was also this transferring of information and all of the different practices that are involved with ensuring that the transfer of information goes as smoothly as possible.
In emergency rooms, when we have to figure out, well, what's their next step? Are they going home? Are they getting transferred? Do they need specialty care? Or getting admitted to the hospital? So say we have an example of somebody needing to be transferred. I can't just willy-nilly send somebody to another hospital. We have to call, we have to get a consult, they have to agree to take the patient, and through that process, then we have to get them transferred in an ambulance. And then we send all of our printed documentation with the patient. Those are all requirements. But if the person who took that consult heard this, this, and this, they knew the diagnosis, they're probably already thinking about what they're going to do, and what's the time frame of them to get here, because they are now in respond mode. So that might be cardiology who take you to the cath lab, because then they can get all these things in play to try to reduce time. So it's really important to be listening and hearing each other at that high level of profession, especially going from an ER doctor to a specialty. Mm-hmm. That's another, skill that's really important in the on-call schedules. And these guys take call for 24 hours at a time. Who knows if they've been in surgery a long time. So that's part of their training as well.
Yeah.
There's so many factors that go into that in regards to what they are listening for, what you're trying to communicate with them. There's so many opportunities for error to happen. It's cool to hear about all of the evidence-based approaches that are then applied to help mitigate that opportunity for error to happen, to make things run more effectively, more efficiently, more timely.
And, thinking about listening and going back to that triage process, we're pretty fortunate in the healthcare system that I work in the community. Our wait times are pretty good. We don't usually have lots of people in the waiting room. We're in a pretty boutique kind of situation, which is good for us. That is not the case in lots of other places. Your triage process absolutely is that listening, and you kind of got to repeat the listening every 30, 60 minutes, because people's health conditions can change. So it's not a one and done either. It's a consistent process.
Great point with the repetition, the double checking, the triple checking. But again, that's built in as part of the process.
Yeah.
If you took that in any other situation in the world, the workplace, the office, the restaurant, the home, you probably don't get that, right? So you do that. But you might follow up. You might say, hey, I heard you say something this morning, and I just want to follow up with you on that. That can be transferable to everyday life. Brett and I did an episode last season about restaurants and what listening is involved in the restaurant. And it's odd because there's a lot of overlap You're talking with the patient, you're talking with the person at the table. You've got kind of this frontline staff, and you kind of have this back of the house staff, but you also have all of these processes in place. One of the things that stuck out from that episode was the person we were interviewing said, you got a lot of people that, especially that are new, that wanted to step in and help and do something that's kind of out of order, and they think that they're helping. But what's actually happening is that it's a disruptive manner in the process. And we got into, if you're on the salad line and you hear the word salad, then it's time for you to enact your skill set. But if you're on the soup line and you start stepping in to help with the tomatoes in the salad line, it's going to screw up the whole system.
Yeah.
Even though you think you're helping. When you take that instance, and then again, in the realm of listening, it's also understanding. It's understanding what your role is, understanding when you get into the emergency department, when you get into the ER, how do you stop people, or do you stop people from stepping in and doing something that's not their role because they want to help, but it's actually screwing up the system because they're not listening to what they need to do?
Well, that's an interesting topic. So some of that might be coaching. Oftentimes if somebody gives you some feedback right away, or a good situation is like a crisis happens. We have something called rapid responses. So there's a big condition change. A great example of that is at the outpatient lab where you're coming in, Brant, having your blood drawn today, don't like needles. You didn't eat breakfast. You were nervous about all of it, and you maybe weren't drinking, and suddenly you get lightheaded and you pass out, right? So we have processes in hospitals to, run to the thing that needs the help. We all do that. But we have policies about how many people are on the members of that team. But in the outpatient lab, it's near the clinic. And so people are very minded to be helping. And so we get over help. And sometimes then we just have an audience.
Sure.
People recognizing that we're good, you can go back to what you were doing. They actually have to say that out loud. So you have to remind people, we're good, we don't need anything else. You can go back to wherever, you came from. Because there's an innate desire to be helpful. And healthcare is huge. It's with people. So we have to work within that and not cause any ruffling of people's egos. So it kind of depends on where it occurs. But I think coaching or then trying to follow up and give feedback, but people also need to be available to reflect, be like, well, was I really helpful there? What did I do wrong? Like, what could I do differently? But, it's like, how did that conversation go? So again, listening is a key component of that. If somebody's giving you feedback, if you don't hear it, nothing changes.
As you were talking about that, like they have to say it out loud, that we've got enough people here, we can send these people out. There are these techniques or practices, and you'd mentioned earlier on too, just how the idea of a checklist really changed safety in the airline industry by having a written checklist that you'd have to go through each time. That now when we think of a checklist, we don't even think of the airlines anymore. We just know that, a checklist is what we do. What are some of the best practices that you've found in your nursing career that have transferred back over into real life for you?
My kids have said this to me, that because of my role in leadership and working with people frequently, they're like, you can't coach us, Mom. Oh. So there'll be things like, well, I learned, or I get excited about it. So, I'd be like, my whole job is just to make you good citizens of this country. So, I think there are things I would say more in my leadership role than just out of being an ER nurse. Certainly, as an ER nurse and just that knowledge base, I get lots of phone calls of, hey, this happened or that happened. Should we be worried about that? Like, you're the advice giver. That happens a lot. I think otherwise, having tough conversations and how you approach that is very transferable across anything you do in life.
This book that came out a number of years ago, and it was on child development. I love this construct and this concept from this book, and it applies into so many different areas in life. And the book is Alison Gopnik's The Gardener and the Carpenter. And the carpenter, a carpenter approach towards parenting And I've done this with management, right? A carpenter approach in management is imposing a rigid structure. This is the way things need to be done, and this is how we do it. Versus the gardener approach is more of a nurturing and providing the right environment for growth. Now, you just mentioned about there's things you look at as a nurse, but when you're in leadership, there's also probably a different way you look at things or see things. In what aspects are we saying, no, we've got to follow this rigid structure and go more of the carpenter approach? And in what areas is it more of the gardener approach of the variables are so unknown, I just need to, just nurture this or work with it?
I love your analogy. I think the ER environment is a great opportunity for that as well, because no two people are exactly the same. What might be in my mind, say, for example, the safest way is you to be in my gurney, side rails up, call light in reach, but my patient might not tolerate that. And that's where the listening and that nurturing piece to say, for you, I think the recliner, if that's your request, can I do that? Can I still give you best practice in ruling out your heart attack, but can we do it in a recliner? And that's just my example. Mm-hmm. Yes, that's where I think the autonomy of the nurses collecting that data, but still working with the physicians, we know what the end point is, but that line to get there can be varied. And it's by that nurse, by the other medical professional and the patient and what their needs are. What does their health look like? It might look different to Drew, might look different to you, Brent, and to me. So how do they get involved in some of that?
So this is kind of going back to where you were talking about that needing that 2 years to get your groove on, is having that competence and competence to be able to make a decision like that. Because I could see if I'm coming in and I'm new and I'm like, gosh, I know I'm supposed to have them in the bed with the guardrails up, but they look really uncomfortable and they'd rather be in the recliner. I don't know if I can do that or not. What do I do? And I might make the wrong decision. I'm taking time. I'm using energy up by doing this. So it sounds like with experience, I don't know, you get to that nuanced level of being able to listen and respond in the right way.
In leadership, some of the things that we used to talk about, and I think it might be similar, what do you need to be tight on and what can you be loose about? So again, experience is a great tool there. Or you're somebody who's just has great open communication, like that nurse might have chosen this, but then have an open conversation with me the next day and be like, hey, I had this experience. This is what I decided. What do you think? Could I have done something differently, or how does that look? Mm-hmm. So again, being available as a leader to listen to whether it's right, wrong, or you might give coaching at that time, it's still productive.
Yeah, I love that.
There is a tremendous amount of emotion that happens every single day. You go to work and the outcome of that work is highly, highly emotional. How does listening play a part in this? We talked about how do you have a sense of humor? How do you go home at the end of the day? How do you process all of this? Sandy, you said it in the beginning of like, we're in this profession for these high adrenaline moments. Regardless of their outcome, that letdown that occurs or all that emotional component, you can see that, you meet somebody at the grocery store that's in this high stress environment and they have a sense of humor about it, or they're coping with all of this stress and all of these emotions. How does listening play a part at the end of the day?
So I think the way I would respond to that is you can listen and be helpful, or you can guide people through whatever situation it is, whether it's the emergency room, at home, or whatever situation you're in. But you don't have to own all of those feelings. Like, I don't have to take them all on.
I like that you might be listening to it, you might have been witnessing it, you might have been a part of that process, but it's not that pain, that suffering, that outcome is not yours. In the exact same time, we're talking about the highly emotional, you may have a fantastic outcome. You also can't just own that and absorb that fantastic outcome either. You need to be able to separate yourself from that emotional component a little bit, because the next thing coming might be the exact opposite, and you still have to keep a level head. You could be proud of the work that you did either way, but you have to be able to separate yourself from that general outcome.
Yeah, I think you can't come into this work and, again, take on that emotion and take on all of that bad stuff without understanding, like, don't take it home. Like, that's not how you live. That's not living. It's work and dedicated to that work. Like I said, I love talking about how you bring your heart and your brain to that job, and listening is a piece of that on both ends, because that's where compassion and empathy come together. But we do live a life outside of the ER, so gotta laugh a little.
Yeah, well, It is such an essential component to our life and well-being. 4 years ago, when my daughter was born, she was born with a congenital heart defect, and if it wasn't for the fast actions of the folks in the emergency room and then at Mott Children's Hospital, like, they saved her life. It's remarkable what the talent can do out there to make these things happen. So it's always grateful for folks that are part of this work. So thank you.
Yeah, you're welcome. You're welcome. In my environment, as you gain experience in the work you're doing, you have more confidence. And then as you get coaching, or maybe it's aging, with better emotional intelligence, there's room then for, you're not thinking about the I or me. You can think about somebody outside of you. Perhaps that's part of the listening piece, is like, because you've come to the plate that it's not all about you. I think that's even a lesson I learned over my career, is like, you could get a little cocky. It's like, well, I know best. Why would I listen to you to tell me how you get out of that wheelchair? Those are lessons learned. And I think whether you're a poet or whatever, again, lessons you can learn over time to engage with people. That's where listening comes in. How best do you get out of your chair? How can I help? And just make those assumptions. It leaves you vulnerable to that person, that you're going to help them, and I'm simply available to you. I think those are all very intertwined, actually.
Yeah.
I always vacillate in my role between, being a nurse at the bedside and in leadership now. Vulnerability and understanding also comes in play with leadership, whether I'm the person being vulnerable to someone else, or I have an employee that needs to be vulnerable with me, and I need to exercise understanding to them for whatever situation they're under. It still might mean that I have coaching to do with them to help them improve or be better, but I can still understand where they're coming from.
Love it.
Yeah, yep. Absolutely.
Sandy, thank you. Thank you, Sandy.
It's been great having you talk with us.
Awesome. I appreciate the ask.
Appreciate it. See you around. Grant, give me your takeaway from this conversation.
My takeaway is that it's not just here's how something is working physiologically, and then here's our emotion and human response to it. But the work that goes into listening, the evidence-based approaches that are researched and refined over time to enhance the level of listening. I don't know, that concept kind of blows me away. That it's like, whoa, there are people that have really thought about this. To do transfer the case for a patient from one team to another, and doing that with the patient, like, well, of course that makes sense, but that's not always been the practice. But man,
right.
I'm just in awe of the level of care that goes into listening in the emergency room.
Yeah.
How about you, Drew? What's your takeaway from this one?
The skill of listening in that environment, I underestimated how critical it was. I knew it was there. I knew it was a component of it.
Mm-hmm.
I anticipated talking with Sandy today and hearing a lot about 50 cc's of this and what does this beep mean? And a lot of this is protocol and practice.
Yeah.
You can't deviate too much. But we didn't talk about that at all.
No.
we talked about human emotion. We talked about compassion. We talked about, the ability to shift a little bit. That is amazing to hear, and took me aside a little bit. That was fascinating. The connection with the patients, the connections with the family, that emotional response, the listening that is involved really dominated the conversation. I didn't anticipate that.
Yeah.
That's my takeaway.
Cool. So you're going to more likely go to the emergency room now if you have an emergency?
No, I just want to go there and talk. Is something wrong, sir? Yeah, can we talk?
Yeah. Just come in with treats or snacks. They always like that.
Yes, exactly. Okay, great episode.
Yeah, good one.
In the description of this podcast, you will find more information and a list of any of the sources that we used.
This podcast is created and produced by Drew Richmond and Brant Christofferson. Editing by me, and the I'm Listening theme music by Drew.
That's me.
That's you.
Brant, I will talk to you later, my friend.
We'll see you next time.
Yeehaw.
Have a good one, Drew.
Bye, Brant.